you're going to use FiO2? B? So, show of hands, how many of you are going to go up on B first if the baby's breathing? Okay, anybody going to go up on FiO2? Yeah. There is no current evidence to basically say that one strategy is better than the other. But we have a high CPAP failure rate. So lung recruitment becomes an essential strategy. Because if your lungs aren't recruitment, you can go up on FiO2 as much as you want. You haven't really recruited enough lung to be able to keep the baby breathing. So what we have agreed as a group is that we're actually going to increase CPAP pressures in increments every 2 minutes, but also increase FiO2 every 30 seconds. And really, a significant amount of the FiO2 titration is kept to clinician discretion. The most important thing is that if we're keeping breathing baby, we do not break the seal. The airway person keeps it there, he manages the baby. His intention is not to disconnect unless we're in a situation where the heart rate is not coming up, in which case we then have to do MR SOPA. Now, I'm going to skip this. What is and how do you get lung inflation feedback? How do you know that you're actually ventilating? Because on PEEP, the baby is breathing. So the most important aspects are improvement in heart rate and saturation. Any other methods? Anything that anybody else knows of? So at this particular point, there is the use of what we call as respiratory function monitors and the Monivent, and I will talk about that a little bit at the end. But really, it's rising heart rate and saturations that guides us. If they're not coming in, you will inevitably then resort to IPPV. Now, are you moving the chest? And that is where the CPR coach comes in. If you're not confident about moving the chest, 2 people can confirm you're not moving the chest. And that would be an indication for you to do MR SOPA, increase your pressure in rapid increments to be able to achieve that. Now that feedback is sometimes very difficult for one person to judge. I mean, in smallest babies that can make a big difference. But this is what is on the horizon. So we now have monitors where we're providing IPPV, which monitor not just the mask lead, but actually provide us with tailored tidal volume reports and feedback about what kind of pressures we are providing to that baby. The most common device in the market is the Monivent Neo. We use it for training. We're not using it clinically at the moment because it's not been approved by the FDA. But there is one trial which basically shows that in babies between 29 and 35 weeks, it provides very good and effective feedback to the people providing IPPV about really whether they're effectively ventilating or not. And when we use that in conjunction with chest wall movement and rise in heart rate, they did a parallel crossover study with people who were not using it and found that you were more likely to achieve a rise in heart rate and saturation in the group that used this than in the group